Imagine discovering that the very methods you have relied upon for decades to prepare your vegetables, the boiling, the simmering, the blending,
Right.
that these methods are actively, systematically destroying the exact chemical compounds your failing kidneys desperately need to survive.
It is a profound realization for many patients.
It is. Today, we are initiating a rigorous deep dive into 25 years of clinical nephrology data. We are going to examine the exact biological protocols required to manage elevated creatinine.
And critically, to halt the progression of chronic kidney disease.
Exactly. This is a critical clinical briefing for those of you over the age of 60 who are monitoring your renal health.
We will absolutely bypass the dangerous internet hyperbole promising to cure your kidneys in 3 days. That is nonsense.
It is entirely baseless. Instead, we are looking at established, peer-reviewed guidelines directly from the Mayo Clinic and the National Kidney Foundation.
Yes. We will map out how 5 specific vegetables, when prepared with absolute chemical precision, can physically alter your blood chemistry.
Stabilize your glomerular filtration rate.
Right, and preserve your remaining kidney function. But I must emphasize, it is essential to recognize the gravity of the protocols we are outlining today.
We are certainly not discussing casual dietary suggestions.
No, we are detailing the exact thermodynamics of food preparation. If you prepare these specific vegetables incorrectly, you are not simply neutralizing their clinical value.
You can actively accelerate your renal decline.
Precisely. When we look at chronic kidney disease, we are observing a cascading physiological failure. Treating this decline requires the exact same rigidity and exactitude as a prescribed pharmaceutical regimen.
Today, we will dissect the biological mechanisms action, the precise nutrient ratios, and importantly, the severe medical contraindications that govern the use of these 5 interventions.
Because before we prescribe any of these interventions, we must establish the baseline pathophysiology.
Right. We need to clearly define why your body is generating the specific warning signs currently printed on your metabolic laboratory reports. Let us begin with creatinine.
That is the logical starting point. It is the marker that causes the most immediate anxiety for patients.
It is. But we need to understand its origin. Creatinine is a direct, continuous chemical waste product.
Exactly. Your daily movement, your baseline muscular function, relies on the breakdown of a compound called creatine to synthesize energy.
And as your muscles utilize this creatine, they inevitably produce creatinine as an exhaust byproduct, which is immediately released into your circulatory system.
Right. For a healthy adult, the normal physiological range is strictly maintained between roughly 0.7 and 1.2 milligrams per deciliter.
And that specific, very narrow range is maintained entirely by your kidneys, which serve as the primary filtration matrix of the human body.
Under optimal biological conditions, yes. The kidneys continuously cycle your entire blood volume, filtering out the creatinine and efficiently excreting it through the urine.
However, as you age or as your renal microvasculature is repeatedly battered by systemic conditions.
Like type 2 diabetes or hypertension.
Exactly. That delicate filtration matrix degrades. The physical filters become scarred and impaired.
Consequently, the kidneys fail to pull the creatinine out of the blood at a sufficient rate. The concentration of creatinine within your bloodstream rises.
And this elevated concentration is precisely what your physician flags on your blood work.
But the clinical danger is not the creatinine itself.
No, it is not.
The danger lies in the systemic failures that accompany a compromised filtration system.
We need to thoroughly examine 2 of those critical systemic failures because these are the secondary conditions that frequently prove fatal.
Right. Hyperkalemia and phosphorus buildup.
Let us look at hyperkalemia first. This is the medical classification for dangerously high levels of potassium circulating in the blood.
When your kidneys are damaged, they lose the mechanical ability to excrete excess dietary potassium.
And as this mineral accumulates in your bloodstream, it alters the electrical gradients of your cells.
Which is catastrophic for cardiac tissue. It leads to severe rhythm disruptions, profound muscle weakness.
And in advanced stages, sudden cardiac arrest.
Precisely. Concurrently, your failing kidneys also lose the ability to regulate phosphorus.
The pathophysiology of phosphorus accumulation is particularly destructive. As serum phosphorus levels rise due to impaired filtration, your parathyroid glands detect the imbalance.
Right, and they release a hormone that actively leaches calcium directly out of your skeletal structure to try and bind with the excess phosphorus.
This process structurally weakens your bones over time.
Right.
But the devastation does not end in the skeletal system.
No, it does not. That leached calcium, which is now circulating in your bloodstream, begins to physically embed itself into the walls of your blood vessels.
This is vascular calcification. You are essentially turning your arteries into rigid, calcified pipes.
Which directly accelerates the severe cardiovascular complications that are the leading cause of mortality in patients with chronic kidney disease.
I want to pause and challenge our focus here, though.
Please do.
If creatinine is merely an inert byproduct of muscle metabolism, just the exhaust from the engine, why should you, as an older adult managing kidney decline, focus so intensely on lowering this specific number?
That is a very common question.
If we spend all our energy managing the creatinine, aren't we just treating the smoke rather than extinguishing the actual fire, destroying the kidney?
That is a critical distinction that dictates how we approach treatment. Creatinine is indeed the chemical marker. It is the smoke signaling the destruction of your nephrons.
The nephrons being the microscopic functional filtering units inside your kidneys.
Right. And the biological reality you must internalize is that human nephrons cannot regenerate.
Once a nephron is permanently destroyed by high blood pressure or inflammatory stress, it is gone forever. Dead scar tissue replaces it.
Exactly. However, the specific targeted dietary interventions required to lower your creatinine directly extinguish the fire you mentioned.
By following the precise protocols we are outlining, you are altering your systemic inflammation.
You are neutralizing cellular oxidative stress and reducing the severe metabolic workload, crushing your remaining functional nephrons.
We are not artificially masking a laboratory value.
No, we are changing the biological environment to prevent permanent cellular death.
Understanding that your irreplaceable nephrons require an environment devoid of inflammatory stress to survive, we move to the first targeted intervention designed to alter that environment.
Red cabbage.
Yes. From a clinical perspective, red cabbage is a vastly underutilized biological tool. It offers an elite nutritional profile specifically calibrated for senior renal maintenance.
A half-cup serving introduces an exceptionally low mineral burden into the system, exactly 170 milligrams of potassium and near zero phosphorus.
The clinical significance of restricting that mineral burden is the absolute foundation of kidney preservation.
When you are managing stage 3 or stage 4 CKD, mitigating your potassium and phosphorus intake is a non-negotiable daily requirement.
It is the only way to prevent the hyperkalemia and vascular calcification we just analyzed.
But red cabbage is not merely a passive food choice valued for what it lacks. It is an active intervention driven by its chemical composition.
Red cabbage is densely saturated with anthocyanins. These are the highly active natural pigments that give the vegetable its dark red and purple coloration.
Current nephrology data indicates that the progression of kidney disease is actively driven by chronic systemic inflammation.
It is not just a mechanical wearing down of the filter.
Exactly. Your immune system's inflammatory cells are actively damaging the fragile kidney tissue.
And anthocyanins intervene directly by inhibiting these inflammatory pathways at the cellular level.
Right. It helps to view these anthocyanins as biological rust inhibitors.
That is a perfect clinical analogy. Just as a chemical coating prevents the physical oxidation and deterioration of metal piping, these compounds circulate through the delicate renal structures,
systematically slowing the oxidative decay of the tissue.
Beyond this protective shielding, red cabbage delivers a pronounced alkalizing effect within your bloodstream.
We must examine the mechanics of metabolic acidosis here. When your kidneys fail, they can no longer efficiently excrete the daily acid load generated by normal metabolism.
Your blood becomes excessively acidic, and this acidic environment acts as a corrosive force,
rapidly accelerating the physical decline of the remaining nephrons.
The National Kidney Foundation mandates the strict management of this acid-base balance.
And red cabbage functions as a potent plant-based buffer, directly neutralizing this destructive acidity without relying on pharmaceutical interventions.
However, to extract these specific chemical benefits, the preparation protocol is absolute.
Anthocyanins are notoriously heat-sensitive compounds.
If you subject red cabbage to prolonged thermal stress, such as boiling or extended roasting, you completely disintegrate the molecular structure of the anthocyanins.
Rendering the intervention clinically useless, you are simply consuming empty fiber at that point.
Therefore, you must consume the red cabbage raw, perhaps finely shredded into a slaw, or lightly steamed for an absolute maximum of 2 to 4 minutes.
There is a definitive visual cue of failure you must monitor. If the red cabbage alters its color to a blue or dull gray, you have structurally destroyed its therapeutic value.
The temperature threshold has been breached. The clinical target to alter your acid-base balance is one controlled serving, administered 3 to 4 times a week.
So red cabbage acts as the chemical buffer, regulating the acidity of the blood before it even enters the kidneys.
But once that blood reaches the nephrons, the physical cellular structures require a direct shield against continuous oxidative damage.
This requirement transitions us to the second clinical intervention, cauliflower.
Cauliflower provides critical biological support with a near-zero metabolic cost to your compromised kidneys.
A half-cup serving registers a mere 88 milligrams of potassium and 22 milligrams of phosphorus.
That extraordinarily low metabolic cost allows cauliflower to serve as the delivery mechanism for a vital class of phytochemicals known as glucosinolates.
Right. When you digest cauliflower, your body metabolizes these glucosinolates into two highly active compounds.
Indoles and isothiocyanates.
Yes. These are aggressive, specialized antioxidants. As we have established, oxidative stress, driven by rogue molecules called free radicals, is the primary mechanism that inflicts permanent, irreversible death upon your nephrons.
By systematically supplying your bloodstream with indoles and isothiocyanates, you are establishing a chemical perimeter.
A direct defense network that neutralizes free radicals before they can physically compromise the irreplaceable nephron tissue.
Cauliflower also functions as a primary source for choline, which brings us to a critical indicator of kidney failure, proteinuria.
Proteinuria occurs when protein molecules, which are normally retained in the blood, begin leaking through the damaged kidney filters and into your urine.
Visually, this often presents as persistently foamy urine. Clinically, it is a severe warning sign.
It demonstrates that the physical structural barrier of the kidney is actively rupturing. Proteinuria is an independent, aggressive risk factor for end-stage renal disease.
Emerging clinical nutrition research demonstrates that adequate choline intake directly supports the structural integrity of the podocytes.
The specialized cells that form the kidney's filtration barrier.
Exactly, helping to reduce this dangerous protein leakage.
To understand the systemic impact of this intervention, we must examine a documented clinical case study.
Consider a 68-year-old male patient operating out of Tennessee. He presented with stage 3A chronic kidney disease, complicated by a long-standing history of type 2 diabetes.
His serum creatinine had climbed to a critical 1.9 milligrams per deciliter, indicating a severely compromised glomerular filtration rate.
Under strict supervision by his nephrologist and a renal dietitian, his daily nutritional inputs were radically restructured.
His protocol heavily prioritized precisely measured portions of cauliflower and red cabbage to buffer acidity and provide oxidative shielding.
Over a continuous 6-month period, integrating these dietary shifts with rigorous hydration management and his existing medication, his laboratory results shifted.
His creatinine levels stabilized and then actively decreased from 1.9 down to 1.7.
That reduction from 1.9 to 1.7 may sound numerically small, but biologically, it represents a profound stabilization of his filtration capacity.
And a significant extension of his kidney's functional lifespan.
But achieving that result relies entirely on preparation. And here, I must push back on the reality of implementing this protocol.
Please.
For you, or any older adult managing these dietary changes, boiling vegetables is universally considered the safest, softest, and most easily digestible preparation method.
It is certainly the most common.
So if boiling makes the cauliflower easier to consume, are we strictly concluding that this convenience completely neutralizes its clinical value?
We are concluding exactly that. And we must analyze the physics of what happens when you introduce cauliflower to boiling water.
The process of boiling fundamentally breaks down the cellular walls of the vegetable.
As those walls rupture, the water-soluble compounds, specifically the critical glucosinolates, the choline and the potassium, leach directly out of the cauliflower and into the surrounding boiling water.
When you drain that water, you are literally pouring the medicine down the sink.
If you then consume the boiled cauliflower, you are ingesting a mass of depleted fiber.
To retain the indoles and isothiocyanates, the cauliflower must be roasted with a light application of olive oil or briefly steamed.
Right. The only clinical exception to this rule is highly specific.
Precisely. If a patient presents with laboratory results showing critically high serum potassium, verging on hyperkalemia, a nephrologist may explicitly direct the patient to boil their cauliflower and discard the water.
In that specific scenario, boiling is used as an intentional mechanical strategy to aggressively leach the potassium out of the food to prevent cardiac failure.
But that is a calculated medical decision made under supervision.
Which underscores our fundamental point. You must treat the preparation of your food with the identical exactitude of pharmaceutical dosing.
Protecting your nephrons with antioxidants from cauliflower is entirely futile if the physical blood vessels feeding into those nephrons are under too much pressure.
A biological shield cannot stop a mechanical rupture.
No. We must shift our focus to the immense cardiovascular pressures driving renal failure. The statistics are absolute.
Type 2 diabetes is the leading cause of chronic kidney disease in the United States, and hypertension, chronic high blood pressure, is the second leading cause.
High blood pressure acts like a mechanical vice. It physically strangulates the microscopic fragile blood vessels, the afferent arterioles, that deliver blood into your kidney filters.
To counteract this relentless mechanical force, we employ the third clinical intervention, garlic.
The clinical efficacy of garlic is not derived from its general consumption.
No, it is completely dependent on a specific volatile chemical synthesis.
Inside a raw, intact clove of garlic, there exists an isolated compound called the zyme, and in a separate cellular compartment, an enzyme called align.
While the clove remains whole, these two compounds never interact.
However, when you mechanically crush, smash, or finely chop the garlic, you rupture those internal cellular walls.
This forces the align and the alanines to interact, initiating a chemical reaction that synthesizes an entirely new, highly active therapeutic compound known as allicin.
Listening to the mechanics of this synthesis, it sounds exactly like mixing a two-part epoxy you would find in a hardware store.
That is an exact biological parallel.
You have two separate, entirely inert ingredients. They do nothing on their own. But the second you crush them together, a powerful chemical reaction initiates.
And the clinical outcomes of synthesizing that allicin are thoroughly documented. Extensive meta-analyses published in leading clinical nutrition journals demonstrate this.
They show that the regular daily ingestion of properly synthesized allicin yields a statistically significant, sustained reduction in systolic blood pressure.
Typically measuring between 4 to 8 millimeters of mercury.
In the context of your kidneys, reducing the systolic pressure by even a few millimeters significantly decreases the sheer mechanical force hammering against your delicate renal microvasculature day after day.
Furthermore, this synthesized allicin delivers potent anti-fibrotic properties.
As kidney disease progresses into the later stages, a devastating biological process called fibrosis occurs.
Your body essentially attempts to heal the damaged kidney tissue, but it overcompensates.
Specialized cells called myofibroblasts become hyperactive, rapidly generating thick, dead scar tissue that aggressively replaces your healthy, functional filtering tissue.
The specific sulfur compounds derived from the allicin have been clinically shown to inhibit the activation of these myofibroblasts,
Directly slowing the spread of this irreversible scarring.
But all of these profound hemodynamic and antifibrotic mechanisms are instantly aborted if you do not adhere to the 10-minute rule.
This is arguably the most critical preparation protocol we will discuss today.
Once you crush or chop the garlic, you must leave it undisturbed at room temperature for a minimum of 10 minutes before applying any heat whatsoever.
Heat instantly denatures the allinase enzyme. If you chop the garlic and immediately drop it into a hot pan, you permanently destroy the enzyme before the chemical reaction can complete.
The therapeutic allicin is never synthesized, and you receive absolutely zero blood pressure or antifibrotic benefits.
The chemical epoxy requires time to set before it is subjected to the disruptive stress of a thermal environment.
We must also issue severe clinical contraindications regarding the use of therapeutic garlic protocols.
Yes. If you are currently prescribed blood-thinning medications, such as warfarin or Plavix, you cannot introduce daily therapeutic doses of garlic without strict, continuous monitoring by your prescribing physician.
Allicin possesses distinct, mild anticoagulant properties that can compound with your medication and increase bleeding risks.
Furthermore, if you are currently classified as stage 4 or stage 5 CKD, any dietary alteration requires explicit nephrologist approval.
And it must be stated unequivocally, under no circumstances should you ever utilize garlic salt.
The extreme sodium concentration in garlic salt will instantly spike your blood pressure, completely neutralizing any theoretical benefit of the garlic itself.
Having established a protocol to lower the mechanical blood pressure utilizing allicin, we must transition to protecting the physical integrity of the internal lining of those blood vessels.
And address the broader systemic environment of the body. This introduces the fourth intervention, the red bell pepper.
In clinical renal nutrition, the red bell pepper operates as a precision tool. It delivers a maximum payload of cellular defense while inflicting minimal metabolic strain on the compromised kidneys.
A single medium-sized red bell pepper delivers approximately 190 milligrams of natural vitamin C.
Vitamin C operates as an essential water-soluble antioxidant that actively patrols your bloodstream,
Neutralizing the free radicals that specifically seek to destroy the endothelial cells.
which are the delicate single-cell layer lining the inside of your renal blood vessels.
At this point, we must directly address and clarify the pervasive medical myth regarding vitamin C and the formation of kidney stones.
Yes, many patients avoid vitamin C entirely out of fear of crystallization.
The documented clinical risk of developing oxalate kidney stones is specifically associated with the administration of massive, synthetic, megadose vitamin C supplements.
Typically pills exceeding 1,000 milligrams per day.
That risk profile does not translate to the physiological doses of dietary vitamin C derived from complex, whole food matrices like the red bell pepper.
Furthermore, the red bell pepper provides an exceptionally safe delivery mechanism for a cardiovascular protective antioxidant called lycopene.
Lycopene is famous for being abundant in tomatoes. However, a standard tomato carries a dangerous potassium load frequently exceeding 400 milligrams.
Making it highly hazardous for advanced CKD patients.
The red bell pepper delivers the necessary lycopene, but strictly limits the potassium to roughly 250 milligrams, and it is entirely devoid of phosphorus.
Beyond the endothelial protection, the red bell pepper serves as a primary mechanism for managing a vastly more complex systemic issue.
A gut-kidney axis.
The red bell pepper provides a specific structure of dietary fiber that is fundamentally necessary to sustain the colonies of beneficial bacteria residing within your gastrointestinal tract.
If your dietary intake lacks this specific fiber, your intestinal microbiome starves and collapses into a state of severe dysbiosis.
I must interject here because the term gut-kidney axis often sounds like a holistic buzzword to patients used to mechanical medical models.
How seriously is the clinical nephrology community actually treating the relationship between the bacteria in your colon and the failure of the physical filters in your kidneys?
It is currently treated with the highest degree of clinical severity. This is not holistic theory.
It is a meticulously documented frontier of modern nephrology, heavily investigated by institutions such as the Cleveland Clinic and the National Kidney Foundation.
Right. When dysbiosis occurs, when the beneficial bacteria die off, pathogenic, harmful bacteria rapidly proliferate in your colon.
These harmful bacteria begin consuming proteins and manufacturing highly toxic biological byproducts.
Specifically uremic toxins such as indoxyl sulfate and picresol sulfate.
Let us trace the exact pathway of those toxins because this illustrates the critical nature of the fiber intervention.
Yes. These uremic toxins, indoxyl sulfate and picresol sulfate, do not remain in the colon.
They actively breach the intestinal wall, permeate the mucosal barrier, and enter your systemic bloodstream.
From there, your circulatory system pumps these deadly toxins directly into your kidneys.
As the remaining nephrons attempt to filter out these specific toxins, the chemicals inflict severe, direct inflammatory and oxidative damage to the delicate renal tubules.
Your gut bacteria are essentially manufacturing a poison that systematically targets and destroys your kidneys.
Maintaining the fiber intake from sources like the red bell pepper feeds the beneficial bacteria,
Suppresses the pathogenic bacteria, and halts the production of these kidney-destroying toxins at the source.
To ensure the vitamin C and the fibrous matrix remain intact, the preparation protocol dictates that the red bell pepper is optimally consumed raw.
Vitamin C is highly volatile and rapidly degrades when subjected to heat.
If a patient insists on applying heat to improve palatability, it must be strictly restricted to a rapid high-heat sauté lasting no more than 2 to 3 minutes.
Slow roasting the pepper, or integrating it into a slow-cooked stew, systematically eradicates the water-soluble antioxidants and severely compromises the structural fiber.
With the vascular pressure reduced, the endothelial cells shielded, and the gastrointestinal environment stabilized, we must address the mechanical output of the system.
The flow of urine and the severe, often hidden complications that arise in senior patients.
This brings us to our fifth and final intervention, asparagus.
Asparagus contains a unique amino acid derivative known as asparagine.
Within the human body, asparagine functions as a highly effective, gentle, natural diuretic,
This mechanical function is critically necessary for older patients suffering from fluid retention.
which typically presents clinically as severe edema, swelling in the lower legs and ankles.
It is also vital for patients battling hypertension driven by fluid overload.
By gently encouraging the kidneys to increase urinary flow, asparagine facilitates the mechanical, physical excretion of accumulated waste products.
Including the circulating creatinine we discussed at the beginning of this briefing.
Concurrently, asparagus provides an extraordinary level of chemical defense by delivering a compound called preformed glutathione.
In clinical biology, glutathione is universally recognized as the master antioxidant of human physiology.
It is the most powerful defense mechanism your cells possess against toxic destruction.
By ingesting preformed glutathione directly from the asparagus, you are immediately shielding your renal cells against toxin-induced apoptosis, or cellular death.
This is exceptionally vital for older patients who are subjected to heavily medicated pharmaceutical regimens.
Or patients who are at a high risk of developing contrast-induced nephropathy following the use of intravenous dyes during medical imaging procedures.
We must also address the severe, debilitating complication of anemia that invariably accompanies advancing chronic kidney disease.
When your nephrons sustain physical damage, they lose the ability to manufacture a highly specific critical hormone called erythropoietin, commonly referred to as EPO.
Under normal conditions, the kidneys release EPO into the bloodstream, where it travels to your bone marrow and explicitly instructs the marrow to manufacture new red blood cells.
When the kidneys fail, EPO production plummets.
Without that hormonal signal, the bone marrow ceases production, resulting in severe, exhausting anemia.
Asparagus delivers a concentrated dose of dietary folate. Folate provides the foundational chemical support required by the bone marrow to synthesize the red blood cells,
Addressing the nutritional deficit on the bone marrow side of this complex biological equation.
It is clinically necessary to briefly reassure patients regarding a highly noticeable side effect of this intervention.
The distinct alteration in urine odor following the consumption of asparagus.
This pungent, sulfurous smell typically manifests rapidly within 15 to 30 minutes of ingestion.
You must understand that this is a completely benign, harmless byproduct resulting from the normal enzymatic breakdown of the asparagine compound.
It is evidence of proper metabolic processing, not an indicator of further renal failure or toxicity.
Regarding the preparation protocol, asparagus must be lightly steamed or roasted at 400 degrees Fahrenheit for exactly 10 to 15 minutes.
The physical texture, the crispness of the stalk must be retained.
If the asparagus becomes limp or mushy, the structural matrix has collapsed, and the heat-sensitive glutathione and folate have been subjected to thermal destruction.
The clinical target is precisely 2 to 4 ounces, consumed 3 to 4 times a week.
Before we finalize the asparagus protocol, we must address a severe compounding risk.
This is critical.
If you are an older adult currently taking a prescribed pharmaceutical loop diuretic, such as furosemide, to manage fluid buildup around the heart or lungs,
Right.
does introducing a dietary diuretic like asparagus place you at an immediate risk of dehydration and acute kidney strain?
Yes, the risk is substantial, which is precisely why individual medical monitoring is strictly non-negotiable.
Dietary interventions are biological actions. They inherently compound with the mechanism of your pharmaceutical regimens.
If a patient introduces a biologically active natural diuretic on top of a highly potent synthetic diuretic like furosemide, they risk inducing severe overdiuresis.
The kidneys are forced to excrete fluid too rapidly, resulting in dangerous electrolyte imbalances.
Acute total body dehydration and a sudden drop in blood pressure that can further starve the kidneys of oxygen.
Furthermore, asparagus is absolutely and strictly contraindicated for any patient-prescribed potassium-sparing diuretics, such as spironolactone.
The combination of the potassium retained by the medication and the potassium introduced by the diet can trigger rapid, fatal hyperkalemia.
Strict oversight by a certified nephrologist is an absolute requirement.
Supplying your failing body with the perfect biological inputs is entirely useless and potentially fatal if your broader administration methodology is compromised by behavioral errors.
We must now explicitly outline the 5 critical implementation errors that consistently undermine and destroy kidney preservation protocols.
Mistake number 1 is volume toxicity. You must unlearn previous nutritional advice and internalize the fact that healthy does not equal kidney safe.
Foods like spinach, avocados, oranges, potatoes, and bananas possess excellent nutritional profiles for a perfectly healthy adult.
But for a patient with compromised filtration, they are highly dangerous because they are incredibly dense in potassium and oxalates.
Consuming these specific items will rapidly overwhelm your nephrons and directly trigger the life-threatening hyperkalemia we've warned you about repeatedly.
Mistake number 2 is the smoothie hazard. Mechanically blending your vegetables completely obliterates the complex fiber structures that normally slow down digestion.
When you consume a fully blended green smoothie, you bypass the stomach's natural pacing.
You are forcing a massive, highly concentrated spike of liquid potassium and liquid phosphorus directly into your rapid absorption intestinal tract.
Your impaired kidneys simply cannot process that extreme velocity of mineral delivery.
The remaining functional filtration mechanisms are instantaneously overwhelmed by the biochemical flood.
To visualize the severity of the smoothie hazard, consider a physical structure.
Okay.
Drinking a concentrated liquid smoothie instead of chewing solid intact vegetables is like hitting a structurally compromised concrete dam with a massive flash flood, rather than allowing a steady, manageable stream of water to flow through the spillways.
That is exactly what happens. The physical structure of the kidney is simply overwhelmed by the sudden, violent rate of delivery.
Mistake number 3 is sodium poisoning.
The American Heart Association broadly recommends a general daily sodium limit of 2,300 milligrams for the average population.
For a patient actively managing chronic kidney disease, that limit is recklessly, dangerously high.
Clinical nephrologists require strict, unwavering adherence to a limit of 1,500 to 2,000 milligrams maximum, and frequently much less.
Adding a single casual dash of soy sauce or utilizing the garlic salt we explicitly banned instantly introduces hundreds of milligrams of sodium.
This triggers immediate fluid retention, aggressively spikes the vascular pressure inside the kidney, and instantly negates every single millimeter of blood pressure reduction you achieved through the Allison protocol.
Mistake number 4 is chronic dehydration, resulting from the behavioral avoidance of nocturia.
Older adults frequently deliberately restrict their water intake during the late afternoon and evening to avoid the inconvenience of waking up at night to urinate.
This behavioral choice inflicts profound, measurable chemical harm upon the kidneys.
Restricting your fluid intake dangerously concentrates the waste products circulating within your blood, including the exact creatinine levels you are attempting to lower,
You are essentially turning your blood into a thick, highly toxic sludge.
vastly increasing the physical friction and the mechanical workload required by your remaining nephrons to filter it.
Mistake number 5, and the most critical systemic error, is engaging in rogue interventions.
You must never alter your physiological inputs or restructure your diet without the direct, explicit supervision of a board-certified nephrologist or a registered renal dietitian.
Every food item you ingest chemically interacts with your pharmaceutical efficacy and directly alters complex laboratory metrics.
Particularly as you enter the severe parameters of stages 4 and 5 of CKD.
Patients are strictly required to log their dietary intake precisely and present this data at their clinical appointments to ensure physiological safety.
Operating independently without medical oversight is a direct path to systemic failure.
To summarize the data presented in this clinical briefing, the management of elevated creatinine and the physical preservation of your remaining kidney function past the age of 60 requires absolute, strict biochemical management.
You must actively mitigate your systemic tissue inflammation through the precise, temperature-controlled application of red cabbage.
You must structurally protect your irreplaceable nephrons from free radical oxidative stress utilizing properly roasted cauliflower.
You must aggressively lower the destructive vascular pressure, strangling your microvasculature by synthesizing allicin from resting garlic.
You must shield your endothelial cells and manage the bacteria of your gut-kidney axis with raw red bell peppers.
And you must facilitate safe, mechanical diuresis and support your bone marrow's red blood cell production, utilizing precise portions of asparagus.
The precise temperature controls, the strictly timed 10-minute preparation methods, and the absolute adherence to the contraindicated warnings regarding diuretics and blood thinners are not casual dietary suggestions.
They are the rigorous, biologically required mechanisms for organ survival.
Consider the following perspective as you implement these protocols. For decades, the general medical consensus viewed the decline of the kidney as an unavoidable mechanical inevitability of the aging process.
The assumption was that the filter simply wore out.
But given the rigorous clinical data we now possess regarding the volatile nature of the gut-kidney axis,
The systemic destruction caused by metabolic acidosis and the profound power of oxidative shielding.
we must shift our understanding. What is extending the functional lifespan of our vital organs is less about attempting to treat the failing organ itself.
And far more about meticulously, rigorously curating the precise chemical and cellular environment that surrounds it.
We conclude this deep dive with that paradigm shift for you to consider. Strict, continuous medical consultation is required. End of briefing.